Welcome to the UP College of Medicine class of 1990.
Good afternoon. We will be discussing updates in the management of allergic rhinitis. These are my disclosures. And these are the objectives of my talk. Is first to discuss the epidemiology of allergic. Hello.
Hello. Good morning,
Hi.
Dr. Recto.
Hi, sorry. I just arrived at CDO, but my lecture naman is recorded, di ba?
Yes po.
Yes. I just wanted to know if there is a background for meron bang background na Zoom?
Nakaset na po, Dr. Marisa.
Nakaset. Na sino to? Cha?
Yes po, opo.
Hi,
Bali, on
Cha.
na lang po yung camera, Dr. Okay na po yung
Wait,
background.
I'll check it lang, ha?
Opo.
Ayan. Oh, I
Yes
think
po,
okay
opo.
ba yung lighting ko? Parang hindi, no?
Hi, Dr. Recto. This is Anna po, class 98. Thank you for joining us po.
Hello. Parang how dark, no? Teka. I just arrived in CDO, kaya parang
Galing ng timing.
pero the thing is, sabi ko nga to make sure, record na lang the lecture kasi I would
Yeah.
want to know kung...
That looks good po. That looks good. Yeah.
Sige. I'm just making kwento. Si Cha, matagal ko na yung kilala kasi we were the batch to do these webinars.
Oh, yeah.
I mean,
Watch niyo po si Father Gaston.
kasi no Father Gaston.
Tama ba?
Class
Di ba
90
sila
po,
yung
opo.
nag-start?
Hindi, actually, the batch before us started it a bit. Sina Dr. Teng Genuino.
Okay. Okay.
Naging parang kami yung pilot na dire-diretso.
Sanay na sanay. Expert.
Kaya nga kaya si Cha has my number. Every time I lecture, tatawag na yan straight sa akin.
Ayan. Kayo yung mga expert talaga yan. Si Cha.
Kasi before, ako yung in charge.
Okay.
At least now, mas successful kasi madami ng sponsors. Nung time namin,
Taghirap.
taghirap.
Taghirap. Hi, Dr. Recto, how do we pronounce your first name?
Marisha.
Marisha, okay.
Oo. Thank you for the invitation, ha? Okay. I'll just silent na myself.
We will.
Congratulations to your batch.
Thank you, Doctor. Good luck, Myra. Dr. Recto. Thank you.
Welcome to the UP College of Medicine Class of 1998 webinar series. As this year's Silver Jubilarians, our class is hosting most of the webinars this year on Mondays, Wednesdays, and Fridays unless announced otherwise. Coming from our successful webinars last year, our 2023 theme is still primary healthcare in the era of universal healthcare. In this current webinar series, we hope to unlock knowledge and discuss interesting and relevant topics for primary care physicians, including GPs, family and community medicine physicians, occupational and industrial health physicians, as well as other allied medical professionals. Here are some reminders for a smooth webinar experience. Firstly, kindly turn off your microphone and video for the duration of the webinar. Secondly, we encourage you to participate in an interactive discussion at the end of the speaker's presentation. Feel free to type in your questions or comments in the Q&A chat box in Zoom or through the comments section if you are watching on Facebook. They will be addressed in the open forum after the lecture. Let us now begin with a short ecumenical prayer. Almighty Father, Father of all creation, we praise and thank you for this day. We come to you at this hour asking for your blessings and help. As we are gathered together virtually, we pray for your guidance as we unlock the knowledge that will be shared to us by our beloved speaker. We ask that you clearly show us how to conduct our work with the spirit of joy and enthusiasm. Protect us from the illness of apathy and hopelessness. Instead, keep the fire and love in our hearts as we work together with our colleagues. We ask that you challenge us to reach higher and farther, to be the best we can for others. Amen.
Good afternoon to everyone on Zoom and those watching the live streams on Facebook and the UP Manila live stream. Before we proceed, let me introduce myself as your moderator today. I am Dr. Myra Ocobilio, one of the Silver Jubilarians this year from the UP College of Medicine class of 1998. I'm an ophthalmologist practicing in Cebu. Allow me to introduce our speaker, Dr. Marisha Stella Recto. Dr. Recto is a professor at the Division of Allergy and Immunology of the Philippine General Hospital and a member of UPCM Class 1991. Thank you for taking time out to join us, Dr. Recto.
Good afternoon. We will be discussing updates in the management of allergic rhinitis. These are my disclosures. And these are the objectives of my talk. Is first to discuss the epidemiology of allergic rhinitis, to present certain unmet needs in the management of allergic rhinitis among patients and doctors, and to present the latest international guidelines in the diagnosis and management of this condition, as well as updated evidence-based strategies for management of allergic rhinitis. So allergic rhinitis is the most prevalent allergic disease globally, affecting almost 10 to 30% of the world's population. In Asia Pacific, there are similar statistics, and in the Philippines, we see that almost 20% of adult Filipinos suffer from allergic rhinitis. Just like other allergic conditions, allergic rhinitis develops because of many risk factors from our environment, such as climate change, pollution, decreased infections, urbanization, and lifestyle like stress, sedentary living, and the westernized diet that can lead to obesity. So all of these seem to lead to an increased risk of allergic conditions. Allergic rhinitis may not pose a big problem with mortality and even morbidity. However, its symptoms can disrupt normal sleep patterns that can lead to impaired performance at school and in the workplace, such as presenteeism, wherein the patient is in the workplace or school but is not concentrating, or is absent because of severe disease. Allergic rhinitis is often associated with comorbidities and has a negative impact on the patient's quality of life. Also, it can pose a substantial health and economic burden for sufferers and society alike. There are several global and local unmet needs of allergic rhinitis, despite all the new pharmacologic agents that have been developed in the past several decades. The first is that allergic rhinitis is frequently undiagnosed. Surveys in the Western world concluded that allergic rhinitis was undiagnosed in about 1/3 of adults with this condition, meaning many patients tend to push it aside, or they don't consider it, or don't even consider it an allergy. And in patients who have diagnosed allergic rhinitis, only around 12% sought prescription treatment. And what can undiagnosed allergic rhinitis cause? The emergence of comorbid conditions that can cause more problems for quality of life as well as health utilization, the exacerbation of allergic rhinitis symptoms, impairment of quality of life, which leads to diminished performance in work and school. Patients with allergic rhinitis often suffer from multiple comorbidities. It has been found that patients with active rhinitis symptoms are 1.5 to 4.5 times more likely to suffer from comorbid conditions. And the most common comorbid condition is asthma, followed by gastroesophageal reflux, sleep disturbances, and chronic sinusitis. Rhinitis has been found to lead to poor asthma control because of what we call the one airway, one disease concept, wherein uncontrolled inflammation in the upper airway can transmit down to the lower airway, either due to reflexes, due to inflammation that is systemic, or due to postnasal drip and contiguous histology of the organs. So you could see that if you do not control your allergic rhinitis, you would have problems also controlling the asthma, and that can even lead to more problems in the patient's quality of life. Patients reporting severe rhinitis have been shown to exhibit the worst type of asthma control, which is almost like patients who are smoking. In new results from a health utilization survey of 1,000 patients, most patients actually have been shown to have multiple therapies to control their symptoms. And why is that? They are looking for medications that will have faster and more effective treatment because what they have is not sufficient. So many patients are looking for increased efficacy in the nose and the eyes because also of the one airway concept. Allergic conjunctivitis is very commonly associated with allergic rhinitis and faster responses. So the main treatment targets that drug development is focusing now for allergic rhinitis and conjunctivitis is faster and more effective reduction of these concomitant symptoms. So the problem now of our patients is the vast majority of them remain symptomatic despite the treatment that we are offering them or that many guidelines have offered. We also have to know certain peculiarities about the disease in Filipino patients that may have implications for management. Many Filipino patients classify allergic rhinitis as moderate to severe, meaning it's affecting their quality of life more than 4 times a week and more than 4 weeks. And it is persistent, meaning it is year-round. We have seen many patients complaining of allergies from January to December with a little peak sometime in the rainy season. And this is different from what we see in the Western countries wherein they have allergy seasons. And this is because the type of aeroallergens that the patients are sensitized to in the Philippines are mostly the indoor allergens, wherein patients are exposed day in, day out to dust mites, cockroaches, molds, and animal dander. Filipino patients with allergic rhinitis also have peculiar comorbidities. Unlike the Western world, wherein asthma is a common comorbidity, we have more patients complaining of the skin allergies like urticaria and dermatitis. And what is remarkable is that 12% of our Filipino patients have more than one associated comorbid atopic condition. Therefore, many of our patients with allergic rhinitis remain unsatisfied. 20% of Filipinos are still looking for the proper management of their allergic rhinitis. So in order for us to give the proper advice to our patients, we have to again go back a bit to the pathophysiology of allergic rhinitis and how to do a proper diagnosis, which sometimes is the Waterloo of our clinicians and our patients. So allergic rhinitis is an IgE-mediated condition that is triggered by an allergen. And we could see here that the IgE in sensitized patients are found on the surfaces of mast cells. With the exposure to the allergen, you would have the granulation of mast cells that would lead primarily to histamine release, which is responsible for the immediate symptoms of sneezing, watery discharge, and sometimes nasal congestion. But there's a second phase to the allergic response, and these are our inflammatory responses that are initiated by T cell responses that can, of course, activate your B cells to produce the IgE, but as well as recruiting eosinophils that are part of the inflammatory response that will cause the nasal blockage, loss of smell, and nasal hyperreactivity. So we have to remember these two phases because these are two important targets of pharmacology for our allergic rhinitis patients. Allergic inflammation now has been seen to go beyond just the eosinophils and histamine. We have seen, because of molecular advances, that there are certain cytokines, chemokines, and even different cells that are responsible for allergic inflammation and that can be potential targets for molecular treatment, mainly precision medicine. And we hope that in the future, with this knowledge, we can get more directed treatment to help control patients with uncontrolled symptoms, because up to now, allergic rhinitis is still considered an incurable disease. An important concept to remember about allergic conditions is that what you see on the surface is not really what is happening underneath. So chronic allergic inflammation results in a hyperreactivity that can persist beyond the acute symptoms. So sometimes the symptoms are diminished, but inflammation retains. And this inflammation is responsible for the recurrences, the flare-ups, the persistence of many of allergic conditions that our patients will suffer. So rhinitis is really an umbrella term for many conditions, but it is characterized by particular or cardinal symptoms like nasal itching, sneezing, rhinorrhea, and nasal obstruction, mainly hyposmia, which is lack of smell. But we have to remember rhinitis is not always allergic. In fact, 95% of healthy adults will sneeze and blow their noses up to 4 times a day. This is part of the normal reflexes that we have once there's irritation in the nose. But it becomes pathologic if the symptoms occur 2 or more consecutive days for more than 1 hour, and becomes chronic if the symptoms last for more than 4 weeks. So here in this table shows the differential diagnosis of rhinitis. Allergic rhinitis presents identically to this other rhinitis, but we can say that there are peculiar ways by which we can really say that it is an allergy. So allergic rhinitis can be demonstrated or divided into the intermittent and persistent forms. And this is based on the number of weeks they have the symptoms and the number of days. So the magic number is 4. So more than 4 days a week and more than 4 weeks is persistent. And mild and moderate severe, depending upon whether there is an impact on quality of life. For example, if there is a poor sleep or inability to work, then it becomes moderate to severe. Now, allergic rhinitis can present in 2 forms. It can be those that are demonstrated through IgE and those that you cannot demonstrate IgE. And this is the local allergic rhinitis. So how can we now diagnose allergic rhinitis, which we found is one of the unmet needs that our patients have? First, we have to do a good clinical history, looking at how long the patient has been suffering, what are the other comorbid conditions, a family history, what are the symptoms and their reproducibility with triggers, what relieves the patient, if it's relieved by antihistamines or steroids, we have to take that. Now, for the physical exam, there's really no pathognomonic symptom of allergic rhinitis, or sign rather of allergic rhinitis. We can see enlarged turbinates, which are pale and buggy, but this is not unique to allergic rhinitis. We can see the rhinorrhea, which can also be seen in any form of viral rhinitis. But yet, we have to still do it to help make your diagnosis of at least rhinitis. Now, how would you know now it is allergic? The best way and the only way is actually to find out if there is specific IgE. And this differentiates it from the other forms of rhinitis, because allergic rhinitis is an IgE-mediated condition. And we can do this either through the skin prick test or through the detection of specific IgE through the blood, through a serum IgE test. So how do we do our allergy skin prick test? We drop an purified allergen on the skin of the patient and prick it superficially with a sterile needle. And if there is the presence of specific IgE on the surfaces of the dermal mast cells, then you would have the granulation of those mast cells leading to the wheal and flare reaction. And so you could see that we can test several allergens at the same time. But there are some patients who, despite that allergy test, will still not be there will not be no positive allergy test rather. And these are patients who may have local allergic rhinitis, which can be elicited upon constant exposure to the same antigen. So it's through challenges that they will be revealed as having local allergic rhinitis. And this is because the IgE is not present in the blood, but rather found only in the organ per se. In the allergic rhinitis and its impact on asthma guidelines, which we use widely, there are certain symptoms that seem to be more suggestive of allergic rhinitis versus other differentials. So we could see here on the left side that the 4 cardinal symptoms are there, but the presence of conjunctivitis together with these rhinitis symptoms will actually help you make a more educated diagnosis of allergic rhinitis. Now, if there are symptoms that are unilateral, or there's just obstruction without other symptoms, or presence rather of mucopurulent rhinorrhea or fever or thick mucus, or epistaxis and pain, or anosmia, because now we know anosmia is related to certain viral conditions like COVID. These are usually not associated with allergic rhinitis, and we have to think of other differential diagnosis. So now that we have a background on the epidemiology of allergic rhinitis and as well as how to approach its diagnosis, we will now look into evidence-based solutions for allergic rhinitis. So allergic rhinitis, just like other allergies, are not curable, but they are preventable. And these management guidelines are what we often use for allergic conditions. First is to identify the presence of specific IgE through allergy tests so that you can avoid the allergen judiciously. Okay, so allergen avoidance will only be effective if there's really a documentation of an allergic reaction. The second is, of course, pharmacotherapy. Okay, and we will be discussing that more later. Next is patient education. Because of the chronicity of the condition, patients have to recognize their symptoms. They also have to know how to use their devices. They also have to know how to respond initially to the flare-up of condition. And finally, for patients whose conditions are not controlled by allergy avoidance and pharmacotherapy, then the patient can be referred to the allergist for what we call allergen-specific immunotherapy, which is the closest thing that can be offered to the cure. We desensitize the patients to the specific allergen until the patients become less sensitive, and thus we can eventually remove medical treatment. We can actually have a long-lasting effect, as well as having less sensitivity to new allergens. So before we go into the management of allergic rhinitis, we have to classify the type of allergic rhinitis the patient has. So if a patient has intermittent symptoms versus persistent symptoms, I've mentioned the magic number 4. If the patient has affectation of quality of life, then we might have to label the patient as having moderate to severe, and classifying them according to duration of symptoms and severity will help you choose the type of treatment for your patient. Another important update regarding allergic rhinitis is to use what we call the visual analog scale that has been introduced by the ARIA group in 2019. And these are very important parameters by which we can decide whether to step up or step down treatment, or if we have to refer the patients for immunotherapy. So you could see here from a scale of 0 to 10, you can show this to your patients, whether adults and children, and they can help or guide you towards the management of your patients. So when we look at pharmacotherapy of our patients with allergic conditions, we often have to consider again the immediate phase response, which is histamine-driven, and the late phase response, which is inflammatory. And most of the time, we give our antihistamines, our H1 antihistamines for the early phase reaction, and for the late phase reactions, we often advise the giving of intranasal corticosteroids. The allergic rhinitis and its impact on asthma therapeutic algorithm states that across the board for the different classifications of allergic rhinitis, oral or local, these are intranasal non-sedating antihistamines, are what is recommended compared to the first generation antihistamines, which have more sedation and and cholinergic effects. No? So we have to be careful right now about the giving of antihistamines, because we would really prefer those that are what we call the second generation antihistamines. And if the severity of the condition becomes more, then we now add the intranasal corticosteroids to help control the inflammatory responses. The rest of the medications, like anti-leukotrienes, are not first line. They are used only as adjuncts to treatment. We give the intranasal decongestions only if we have documented the congestion. No? Allergen and irritant avoidance, of course, is a no-brainer, because the patient cannot get well with the constant exposure to this allergen. And of course, in more severe and uncontrolled conditions, then we can suggest immunotherapy and off-label the use of anti-IgE. So in the latest allergic rhinitis and its impact on asthma guidelines, they actually change the way by which they give recommendations. They use the first grade guideline, which was integrating real-world evidence with a chamber study. It provided a clear strategy to identify the approach to treatment, whether to step up, step down, etc. And it is based again on the visual analog scale, the type of allergic rhinitis and current treatment. And it is the first guideline to provide a specific treatment recommendation based on treatments, current treatment, visual analog scores, presence of congestion, exposure to allergen, and by expert consensus. So how do these guidelines work? First, the physician will decide on the treatment approach based on the visual analog scale, checking if the patient has the intermittent rhinitis or persistent rhinitis and previous treatment, and will either step up, step down, continue treatment, or initiate. Then provide specific treatment recommendations based on evidence like the grade system, real-world evidence, and chamber study evidence, as well as current treatment and visual analog scale. And in the first year, which is the first-line treatment, the antihistamines are always there, whether oral, intranasal, or the use of the topical eye drops, because many patients with rhinitis have conjunctivitis. You can use an LTRA together with the antihistamine, but by itself, it might not be as effective as the antihistamine. Then the second tier would be the use of your intranasal corticosteroids. And now the third tier, they have singled out a specific combination of intranasal antihistamines, azelastine, and fluticasone, an intranasal corticosteroid, which has been tested in many clinical trials and can be recommended in their guideline. And in the fourth level, that is when you only give your oral corticosteroids a short course. And if this is still not sufficient, then your patient may be referred to the allergist for allergen immunotherapy. So we will now start dissecting these ARIA guidelines. How did they come up with these recommendations? First of all, when we think of an allergic condition, we will think about oral antihistamines. And what do the experts say about oral antihistamines? Okay, they have found, based on the gathering of their evidence, that oral antihistamines are actually less potent than intranasal corticosteroids. And this has been proven in the grade evidence, as well as real-world data. However, many patients still prefer the oral antihistamines, but we do not yet know information on patients' preference. So nowadays, the guidelines are focusing on what the patient will prefer also. It has to be a joint or collaborative treatment, because if the patient will not be able to do your treatment, then whatever recommendation will not be effective. So they found here that there was good agreement between the grade and real-world data about oral antihistamines being less potent than steroids, but there are certain that's not confirmed, no? Like about the patient's preference. Now, what about the intranasal antihistamines? Okay, the intranasal antihistamines have been found to be less effective than intranasal corticosteroids. Okay, because remember, antihistamines are not as anti-inflammatory as your intranasal steroids. And this has been proven in the GRADE studies, real-world data, as well as clinical trials. Okay, this is what we call the chamber studies, which I'll be discussing later. Now, what we have to remember, though, is that even the intranasal corticosteroids are recommended as first line in the guidelines for moderate to severe rhinitis because they control symptoms better. Intranasal antihistamines have a much faster onset of action, and sometimes that is what the patient wants, immediate relief. And this has been found that intranasal antihistamines are more faster to show their effect in the symptoms as based in clinical trials. Okay, so we have also comparisons between intranasal antihistamines and oral antihistamines, and it has been found that the intranasal antihistamines are more effective because also of their fast onset of action. Now, what about the intranasal corticosteroids? Intranasal corticosteroids are potent medications and are the first-line therapy in moderate to severe rhinitis and proven in the GRADE and real-world data. But they should be weighed against its slow onset. So the onset of antihistamine of intranasal steroids takes a few hours to a few days, no? So you could see that some patients will be under intranasal steroids, they will still be complaining of symptoms if you give it alone. That's why the onset of action should be considered, okay? Because that is what our patients really prefer. And you could see that even in clinical trials, it has been found that the intranasal steroids do not work as fast. So what if we combine? Remember, if we use our intranasal corticosteroids with an antihistamine, it makes sense because you are taking care of the histamine response and you're taking care of the inflammation. And so what if we give our intranasal corticosteroid with an oral antihistamine? So far, the evidence has found that combining this offers no advantage over the use of intranasal steroid alone. And this has been shown in studies of the GRADE and real-world data. So what about combining an intranasal steroid with its effectivity but its slow onset and an intranasal antihistamine with its fast and more effective onset? And you could see that intranasal antihistamines with intranasal steroids was more potent than intranasal steroids alone, as seen by the GRADE and real-world data, and that a particular type of combination azelastine and fluticasone was effective within minutes. So it actually highlighted these combination drugs, the two important needs of our patients, to provide effective and more rapid acting allergic rhinitis medication, especially in those with moderate to severe conditions. So if we summarize the hierarchy of treatment according to the next ARIA guidelines in 2020, our first line always for allergic rhinitis, like other conditions, is oral antihistamines, and this can hold for the intermittent type of rhinitis. It is the least potent, but it is oral, and the patients prefer it. Now, intranasal antihistamines are less effective than the intranasal steroids, but are rapidly acting. So we want to have a better choice. We use the intranasal corticosteroids, which are effective in all aspects, but slow in onset. And the patients get impatient with their treatment. So if we give an intranasal steroid with the oral antihistamine, no efficacy was seen, no advantage to giving intranasal corticosteroids alone. So that is why the experts in the next generation ARIA have recommended the intranasal corticosteroids with intranasal antihistamines as the most effective and rapidly acting form of treatment for allergic rhinitis. And this is actually the paradigm shift we mentioned, wherein instead of just giving antihistamines or combining intranasal steroids with a separate oral antihistamines, we join the two to get the best effect. So this is the reason why the international guidelines have actually recommended fixed nasal nasal corticosteroids with nasal antihistamines over the nasal corticosteroid alone. Okay, so that is actually the recommendation. And also in a latest guideline, which was the International Consensus Statement of Allergy and Rhinology, which is the IFAR guidelines for allergic rhinitis in 2023. They also have recommended, based on grade evidence, that oral antihistamines have a strong recommendation using the newer second-generation antihistamines. Intranasal corticosteroids also have a strong recommendation, and it should be used rather as first-line treatment in allergic rhinitis. The nasal saline has a strong recommendation as part of the treatment strategy, but cannot replace our intranasal corticosteroids. And the combination of intranasal corticosteroids with an intranasal antihistamine has a strong recommendation for combination therapy when monotherapy fails to control your allergic rhinitis symptoms. So now we will go into one of the latest breakthrough medications that we can offer our patients with moderate to severe persistent rhinitis in the form of what we call azelastine fluticasone in a single intranasal spray. And I'll be sharing the clinical data. So in this study, looked at pharmacokinetics, comparing the use of azelastine fluticasone versus just fluticasone alone that is branded versus generic. They found that the result is a more efficient intranasal absorption and that the plasma levels are much below the threshold for systemic side effects. Now, in a state-of-the-art trial designed for seasonal allergic rhinitis, wherein they use in these patients either the combination Azeflu or fluticasone propionate and azelastine separately versus placebo, and they looked at the effect on total nasal symptom scores over 14 days. And they found out that the azelastine fluticasone was better in treating the overall rhinitis symptom complex, that it was twice as effective as intranasal fluticasone or azelastine alone in relieving both the nasal and ocular symptoms. So we could see that it is not actually the combination drugs that will work. It's the molecule itself that when it is together in one preparation, it would have a superior effect. And also in this study, they found that azelastine fluticasone combination treatment significantly relieved all nasal symptoms from congestion, nasal itching, rhinorrhea, and sneezing significantly. There was also, remarkably, a significant relief from all ocular symptoms, and this is what our patients are looking for, controlling the rhinitis as well as ocular symptoms. And you could see that almost as much as 50% improvement of azelastine fluticasone combination treatment for patients with allergic rhinoconjunctivitis. And regardless of severity of condition, of allergic rhinitis condition, azelastine fluticasone nasal spray was effective for treating patients remarkably, compared to the separate kinds of treatment of fluticasone versus azelastine. Now, in another study looking at long-term data of 1 year in patients who had chronic rhinitis, so given either azelastine fluticasone or fluticasone alone, and this was observing the effects on the nasal symptom scores over a 12 months treatment. And compared to the comparator, which is the plain fluticasone nasal spray, you could see that azelastine fluticasone effectively revealed overall nasal symptoms and thus, of course, the quality of life of patients. And that the relief in the total nasal symptom score reduction was faster in patients who were given the azelastine fluticasone combination compared to fluticasone. So you could see the rapid efficacy as seen almost as fast as 2 times by the first day, relieving or achieving almost a 100% reduction in nasal symptoms compared to patients who are given fluticasone alone. And in the first month of treatment, you could see that there was already a significant difference in that many of the combination treatment reached their 100% treatment response. Now, what about the chamber study? This is very interesting because it simulates the real world scenario wherein we have allergic patients who are put in a room and they actually are bombarded with allergens and they are given certain treatment protocols. No, they are randomized to certain treatment protocols. And in this group of patients, some were given the combination of the azelastine fluticasone. Some were given actually fluticasone separate with an oral antihistamine loratadine, that's the one in the orange bars, and in green placebo. And you could see here that within 5 minutes of bombardment, after bombarding them with allergen, they are given their treatment within 5 minutes, the dramatic improvement of symptom scores with azelastine fluticasone versus that of fluticasone plus an oral antihistamine. You could see that there really is a significant, a faster difference and a more sustained and significant response with intranasal antihistamines and intranasal corticosteroids. Now, of course, for every medication, safety is an issue. And in this kind of treatment, which we was assessed over 14 days, looking at treatment emergent adverse events, the most common reported ones were that of headache, dysgeusia, epistaxis, and sometimes mucosal erosion, especially if they did not use their medication properly, wherein we have to make sure that the direction of the spray is not towards the Kisselbach plexus or towards the septum, but towards the side. So these are relatively mild events, no? And that overall, the proportion of subjects with treatment-associated events was similar for both groups compared to fluticasone treatment, and most of these were mild in nature. So in conclusion, allergic rhinitis is the most common allergic disease worldwide and poses a big socioeconomic burden due to its chronicity and impact on quality of life. There are still several unmet needs in the management of allergic rhinitis experienced by both doctors and patients. And the latest international guidelines on the pharmacologic management of allergic rhinitis has highlighted that there is a paradigm shift, that the use of intranasal antihistamines in combination with intranasal corticosteroids in a single preparation has proven to have the best evidence in providing control of allergic rhinitis symptoms. MP-Azeflu is more effective than fluticasone or azelastine alone for all nasal and ocular symptoms. Azelastine fluticasone is more effective in chronic rhinitis than fluticasone alone. The onset of action of azelastine fluticasone is around 5 minutes as documented in the real-world data of chamber study. And azelastine fluticasone was deemed to have a similar safety profile compared to fluticasone alone or azelastine alone, with dysgeusia or bitter taste as a common adverse effect. So I hope with that we have given you something new to use in treating your patients with allergic rhinitis, and that the evidence has pointed to some very fast and effective treatment which you can use now in your clinical practice. So thank you very much for your kind attention.
Thank you very much, Dr. Rector, for that very comprehensive presentation. We learned a lot. Before we entertain questions, we'd like to thank our sponsor, Beatrice, for helping us make this webinar possible. We'll start with question number 1. In the evaluation of allergic rhinitis, Doctora, is family history important? Can it be passed from parent to child?
Hello, good afternoon, everyone. Well, allergic conditions are really genetic in nature most of the time. I'm saying most of the time because now there are some evidences that the environment has a big role also in the emergence of these conditions or development. So it is a combination of gene-environment interactions like the other non-communicable diseases. So a person who has a genetic history of allergy, and it is an autosomal dominant passing, no, can also pass it to their progeny. Now, what we're seeing now also is that some persons who do not even have a family history of allergy are already getting allergic conditions, no? And this is because of the phenomenon we call epigenetics, no? When the environment, like for example, pollution, climate change, sedentary lifestyle, westernized diets, lack of microbial exposure, all of this can have or affect the way the genes are expressed. And in a person who was not allergic, the person may become allergic, and this time this person passes it on now to their progeny. So that's why allergies now are becoming epidemic. Now, can a mother pass it to her child? Yes, because of genes, but not because of breastfeeding, not because of transplacental transfer. No, it's really because the child has the gene from mother or father or both and is exposed to our current environment. They can really get allergies.
Thank you, ma'am. Do you have any recommendations for patients with allergic rhinitis but who happen to be pregnant? Does it change the management in any way?
Well, there are only a few antihistamines that are called category B, di ba? Based on our classification of safety during pregnancy. So yung ating class category A, di ba, or class A, these are the ones that have been tested in human subjects and are deemed safe for use. But not a lot of studies have been done in pregnant women because of ethical reasons. So based on previous data, there are some antihistamines that are recommended, we call class B, because they have shown in animal studies that they are safe. And in pregnant women, those that have this evidence are loratadine and cetirizine, as well as diphenhydramine. So, and then category C, of course, is yung may toxic effects, which we haven't seen in our patients. Now, some patients ask, if I'm already taking the antihistamine, I find out I'm pregnant, will something happen to the baby? Not really. It's just that there are not enough studies, or not a lot of studies that have been tested these antihistamines on pregnant women. But anecdotally, I have some patients who have taken some of these antihistamines that are not in the category B, and so far, they are okay.
Yung sa antihistamines po, are there recommended ones that don't cause that much drowsiness? I mean,
okay, that's a good question. You know, the first generation antihistamines like diphenhydramine and hydroxyzine, they are known sedating antihistamines. No, they also have a lot of anticholinergic effects. But the newer generation antihistamines are those that are less sedating and also non-sedating. Okay, so merong may konting sedation, some of them. And cetirizine and levocetirizine are part of the slightly sedating. Now, the non-sedating ones, the truly non-sedating ones so far in classification are bilastine and fexofenadine. So there are those, though, that still complain na even these particular antihistamines, they are still sedated. So it is, again, an idiosyncratic reaction. Some people really are just cannot tolerate the antihistamines and they get very sedated.
what if yung symptoms po na nararamdaman ng patient, it's more of like cough? They think it's allergic cough, not so much nasal congestion or itching or sneezing. Ano po yung label na dapat gamitin for that?
Yeah, I saw the question, and the one who asked the question is right. It's not in ICD-10 because it is not there. There's no such diagnosis as allergic cough. Okay, if a person is coughing, it can maybe, and it's allergic in nature, it can be two things. It can be due to postnasal drip that's occurring because of uncontrolled rhinitis, or due to asthma itself. And remember, asthma does not always have wheezing or difficulty of breathing. They can just cough. So if you have both allergic rhinitis and asthma, you can also have chronic cough because of what we call the one airway, one disease concept. When there's inflammation in the upper airway, okay, like the nose, there's also concomitant infection or inflammation rather in the lungs because of common histology, common reflexes, and the continuous spread or hematogenic spread of the allergic inflammation. No? So when you control a cough, you do not just look at the lungs, you also have to look at the nose and control as well the rhinitis. Now, many people tend to dismiss rhinitis and say it's going to go away later, but they don't realize that there's an inflammation continuously going on, and that will eventually lead to asthma later. So malaki talaga yung risk to develop asthma in patients with uncontrolled rhinitis.
So people shouldn't just dismiss it as they're going to outgrow this allergic rhinitis. And
yes, there's no such thing as outgrowing an allergy because it's already a genetic change. Okay, they cannot outgrow genetics. It's going to be for life. It's just that some people will have remissions, times of quiet periods, maybe because they're away from their allergen, but then it can always come back even in the geriatric age.
okay. Some patients are medyo confused. Who should they consult if they have what they think is allergic rhinitis? Do they go to their GP? Do they go to an allergologist, an ENT, or pulmo?
Okay, so let's put things in context. Allergic rhinitis is the most common allergic condition. And most of the time, the general practitioners are the ones who see these patients because they are relatively mild, no? Lalo pa yung intermittent that they come once in a while. But when the allergic rhinitis becomes persistent, okay, or moderate to severe, wherein the quality of life is affected, then many patients are referred to the specialists. Now, most of the time, because they are also a lot and they are known to be the experts in the nose, the ENTs are the ones who also see these patients first. In our system, most of the patients go also straight to the ENT because it is rhinitis. Now, what happens when do you get referred to the allergologist? Some people do not respond to pharmacologic measures, okay? And they do not know what their trigger is. It is just rational that you cannot control the condition if the trigger is always there. So that is when they are referred to the allergist for allergy testing to identify the trigger. And if together with pharmacology, avoidance measures are not feasible, then we have immunotherapy. That is what the allergist does. This is the allergy vaccines or the shots wherein we desensitize the patient until they get immune to the allergen. So if it is dust mite, we inject the dust mite like a vaccine until the immune system will not be responsive to the allergen anymore. Now, the pulmonologists sometimes also see allergic rhinitis, especially in patients who have the uncontrolled asthma. So, lahat tayo, whatever specialty, we can treat allergic rhinitis. It's very common. Now, it is certain indications wherein patients will, in the Philippines, they can go to any of the doctors they choose. That's the beauty of our system. So in our case, we usually get more of the persistent and the moderate to severe. So, you know, it's all wherever the patient wants to go, wherever they feel comfortable and get the best care.
Okay. Does diet have any role po in flare-ups or in the treatment of chronic rhinitis, allergic rhinitis?
Okay, so when people hear allergy, the first thing they think of is I'm allergic to a food, okay? And the only conditions that are directly affected by food antigen are atopic dermatitis maybe and food allergy, cutaneous manifestations. But respiratory manifestations of food allergy is very rare. So there's really no relationship. But people who are having food allergy may also get allergic rhinitis just because of their genetic tendency to develop allergies. So when people have one atopic condition, it's not unusual they will have several other kinds of atopic comorbidities.
Yung mga oral antihistamines po, is there age limit? Can you give it to very, very young patients, like just a few months old?
Okay, we have to be careful about the neonatal period. That's the first 2 months of life because their metabolism is different. They can tend to retain the medication, and it's dangerous to give them antihistamines because of the fear of what we call SIDS, sudden infant death syndrome, wherein they will not breathe spontaneously because of respiratory depression. So some antihistamines, most of them are indicated for 6 months and above. And there are some that are really just with studies of 12 years and above, no? So there are certain antihistamines that can be given in children, like cetirizine, because there is a milligram per kilogram body weight dose. There is also levocetirizine. There's also loratadine. There's also bilastine, also has a pediatric preparation. So there are those with particular indications in children. But for the adults, they have a wider choice of antihistamine.
Ma'am, can you comment on the use of yung mga menthol inhalers? Diba, madali kasi siyang bilhin eh, no? People use it commonly.
I see people, they buy for the rhinitis, no, yung what you call that nasal inhaler, Vicks ba yun? And then or else they use the mga tiger balm to breathe, no? But you know, if you are truly allergic, you are going to get more irritated than relieved, okay? Because these treatments, they have scent, okay, and they are very strong smelling, so they can cause reactions for the allergic patient. So maybe if you have a cold, an ordinary cold, it can be helpful. And if you're not atopic, we're very careful with what we give atopic persons, no? Because they tend to react more than the regular population.
For patients pa who've been previously diagnosed with allergic rhinitis, I imagine some of them will get confused if they have new infections, like maybe the flu or
COVID.
wag sana COVID. Oo. How can they tell po the difference?
Okay, very good question. You know, people come and say, may allergy kami. Sa buong bahay, may allergy kami. Okay? You know, first of all, infections are infections, so they're contagious. If a whole household has symptoms, most probably it's not an allergy. Okay? And if there are systemic symptoms like fever or sore throat, even though there's rhinorrhea, clogging, and sneezing, that is still a viral infection. Now, there are those without fever, and that's why sometimes it's difficult to tell. But if you are giving an antihistamine or you're taking already an antihistamine and there's no relief, most probably this is not an allergy. It's already a viral infection. So if there is hyposmia or anosmia, that is usually not an allergy. Okay, that is probably COVID already. Okay, so we have many patients who say allergy. That's why during our the COVID lockdown, a lot of us allergies are doing online clinics because patients will go to us saying they have allergy when it's really COVID.
Thank you very much for that po. Some patients are medyo would like to know also if may mga herbal remedies ba daw for allergies po?
Okay. There's no good evidence about the herbal remedies. Some people will claim that they work better with certain herbs, no, or some what we call phytotherapy treatment, but the evidence is not very strong. And I would like to caution people who like the herbals, no, hindi porket herbal hypoallergenic na yon. We have had several cases of adverse reactions to herbal medications, and some of them are actually quite serious, no? So again, for the allergic person, we really don't want to give too much herbal medication because they can react even to the herbs. So sensitive, remember the immune systems are programmed to be very hyperreactive. Kaya hindi pwede kung ano-anong pinapahid, kung ano-anong kinakain, or whatever treatment. Kasi baka mamaya yan pa yung maging cause ng problem nila, yung reaction to the herbal medicine.
Ma'am, we have many questions on the safety of daily use of oral antihistamines. How long can they take it ba na they don't need to worry po?
Well, antihistamine, okay, you cannot cure allergy, right? There's no cure. It's lifelong. And so in allergy, theoretically, the person should, if they have persistent type of allergy, they have to take the antihistamine every day for improvement of their quality of life. But long-term use, most of the studies are done only up to 1 year. Beyond that, walang studies that show that it can be taken indefinitely. But based on my practice, I have given some patients long-term antihistamines, the ones that I know are safe, no? The ones that have no effect on long-term on their kidney or liver functions. So meron namang ganon. But in the field of allergy, especially allergic rhinitis, if you cannot remove your antihistamine, there is an alternative treatment that will give you longer protection without medication. And this is the immunotherapy. So in patients who cannot be off their meds, they don't want to take it for long-term, they don't want to take a tablet every day, we can give immunotherapy. And it comes in two forms. One is a injection, which they get every month for around 3 years. Or they can take, and now we have a sublingual tablets. No, that's my tablets we put under the tongue every day for 3 years. And after 3 years, tapos na. And that effect can last for years or decades even after matapos yung last shot. So you see, antihistamines and the other treatments, they're only good as long as you take it. But once you stop it, it doesn't change the course of allergy. It's immunotherapy that will. So yung mga persistent, ayaw na maggamot, these are the options we can offer.
Ma'am, madami pa pong questions, but maybe I'll ask you to state lang po again, ano yung mga recommended na first line of treatment for allergic rhinitis?
Okay, based on the guidelines I've mentioned earlier, it seems no, that the intranasal antihistamine plus the intranasal corticosteroids, which we now have in the market, no, are the first line because of their total effectiveness and their fast onset of action, because that is what the patients want, no, for their daily lives. Now, if for some reason the person cannot avail of this, no, then the intranasal corticosteroids are the second choice, no. Sometimes we also give the oral antihistamine that is second generation for our patients. So we follow that four-pronged approach. First, identify the allergen through allergy testing and avoid if you can. Then you do the pharmacotherapies, as I've mentioned, what the latest guidelines are recommending, the combination treatment. The third is immunotherapy if the two fail. And the fourth is patient education about the chronicity of their disease and how to use their devices, what side effects to experience. Yun yung the holistic treatment of allergic rhinitis.
Dr. Recto, thank you very much for this. We are grateful for your time and your energy. We present you with a certificate of appreciation. If you still have energy to spare, ma'am, we might ask you to type some of the answers sa remaining questions po.
Okay, thank you.
Thank you very much, Dr. Recto. Class 1998 would also like to thank those who helped make this webinar possible: the University of the Philippines, Manila, the UP Medical Alumni Society, the Postgraduate Institute of Medicine, the UP Information Management Service, and our sponsor for this webinar, Viatris. We invite all of our viewers to join the next webinar on mRNA vaccines. Our expert speaker is Dr. Arthur Desi Roman, a clinical associate professor at the Division of Infectious Diseases, Department of Medicine, UP-PGH, and the Medical Specialist 3 and the overall training officer of the Research Institute for Tropical Medicine, Department of Health. The webinar will be held on July 14, Friday, also at 12 noon. You can use the same Zoom link to register in advance, or you may use the QR code shown here. For attendees to receive your attendance certificate, kindly answer the evaluation form before 1:30. You can access this through the QR code. We have posted the URL in the chat box. You will be able to receive your attendance certificate only after answering the evaluation form. Kindly expect our email in a few days. Please ensure that the name you enter in the form is in the same format that you want to appear in your certificate. See you next time as we continue to unlock knowledge for primary care workers and allied medical professionals. God bless you and stay safe.